When we assess a pulse, what you are actually feeling is a pulse wave that got created when the blood was ejected from that left ventricle into the aorta, creating this wave that travels down through the arteries so that we can feel them at specific points in the body. In your A&P book, you were introduced to where pulses can be palpated, and the important thing that you have to keep in mind when you're trying to find a pulse is the fact that you have to palpate that artery by compressing it up against a bone so that that pulse wave can be felt. Now, the amount of pressure that you use is going to be determined by the location of the pulse. For example, when we are trying to find a radial pulse, we may have to use a little bit more pressure to get that artery rolled up against the radial bone so we can feel the pulse wave. Or if we were doing a pedal pulse, you're not going to use very much pressure because typically those are lesser in amplitude because that pulse wave has had to travel so far, and patients may have some peripheral vascular diseases that are preventing that. So the strength in which you are able to feel that pulse is different in those two sites. We know the pulse is controlled by the brain and by the autonomic nervous system. In neuro, you learned about the parasympathetic or cholinergic portion of the autonomic nervous system, and that this is the part that kind of slows the body down to return it back to normal. You learned about the sympathetic or adrenergic nervous system, which is responsible for the fight or flight mechanism. So it is going to speed up heart rate because it's trying to get oxygen and nutrients to those cells so that they can either fight off the stressor or run from the stressor. When we are assessing a pulse, one of the first things we do is count the number of pulsations felt in 1 minute. Now, this is the primary thing that is done by anyone who assesses a pulse. And we then compare the number of pulsations that we felt to what the normal ranges should be. In an adult, when you assess a pulse for the first time, you always assess it for 1 full minute. And then after that, if the pulse had a normal amplitude, which we'll talk about in a minute, and a normal rhythm, a regular rhythm, then it would be okay to count how many pulsations that you felt in 30 seconds and multiply that number by 2. But anytime it is the first time that you have ever assessed a pulse on a patient, you should always palpate it for 1 full minute and count the number of pulsations. Now, in infants, because they're tinier and their metabolic rates are higher, their heart rates are going to run between 120 and 160. When they get to be 2 years old, start slowing down to the 70 to 120 range. And then when we look at 12 to 14-year-olds, it becomes 80 to 90. Now, one very important thing that we assess is the amplitude or the strength that we're able to feel that, because that is really telling us very important information about what is going on in the heart. Normal amount of blood that is ejected in one heartbeat is known as the stroke volume. And normal stroke volume is 70 milliliters of blood, just a little over 2 ounces. Now, if that amount has been ejected, the amplitude of the pulse is going to be 3 plus according to your ATI book. However, if they have any sort of heart failure, then the amount of blood that got ejected may only be 30 milliliters of blood. Therefore, that pulse wave that got created is not going to be very strong. Therefore, that strength that you're able to feel that pulse is going to be much weaker. If you're not feeling a pulse, that is great concern, because when we look at pulses, it's telling us whether or not blood got to the area carrying the oxygen and the nutrients that was necessary for blood to get. As I mentioned, the strength is known as the amplitude of the pulse. So the scale that is given to you in ATI is 4 plus is a bounding pulse. This is considered abnormal in most instances. One of the things that we have already talked about is there are things that we need to assess, information we need to gather prior to assessing vital signs. And if this patient had been exercising and we assess their pulse, we're going to expect it to be a 4 plus pulse, because that heart has been really pumping out the blood to all of those cells during exercise. However, if you find this in a patient who has not been exercising, the adrenergic nervous system has not been kicked in, it is definitely abnormal, and we would want to start trying to determine the reason for the abnormality. 3 plus is strong. Let me correct what I had said earlier. 2 plus is considered normal because it's easily palpated. You don't have any trouble finding it. You don't have any trouble counting it. 1 plus is barely palpable. It's diminished. We do consider this to be abnormal. Commonly find it in our geriatric population in doing pedal pulses. And then 0 means that there is no pulse felt. And of course, this is going to be abnormal because it reflects that no blood is getting to that area, and as a result of no blood getting to that area, those cells are not receiving oxygen and nutrients like they need, and investigation would need to occur as to why you were not feeling that pulse. The rate is, again, the number of times we feel those pulse waves. First time you take a pulse, you take it for 1 full minute. Subsequent vital signs and assessing pulse, you can take it for 30 seconds, multiply that number times 2, which will give you the number for the full minute that you will document. Now, again, one very important thing that we assess with the pulse is, what is the rhythm? When you think of rhythm, if you're familiar with music, you know that music has a rhythm to it. These pulsations are going to have a rhythm to them. Regularity, we look at, is the spacing between each of the pulsations equal or not? In the heart, the SA node is responsible for triggering the electrical impulse in that heart. The electrical impulse starts at the SA node, travels to the AV node, and during that time, the atria will contract. The conduction goes through the AV node, down the bundle of His, into the right and left bundle branches, so that the right ventricle and the left ventricle are being supplied with electrical conductivity. And then it ends in the Purkinje fibers, and at the Purkinje fibers is what stimulates the right and left ventricle to contract. Now remember, the atria contract together and the ventricles contract together. When everything is working right, the rhythm is going to be regular. However, sometimes there are problems that occur in that conduction system that make that pulse irregular. It may be related to the SA node. It may be related to the AV node, because the AV node in the heart is really the gatekeeper. And sometimes the SA node is sending way too many impulses to the AV node, and the AV node says, I cannot let all of these electrical impulses down to the Purkinje fibers, because then the ventricles would be contracting too much. And then, of course, you can have problems within the heart itself, because you need to keep in mind that the heart can, any cell in the heart can generate an electrical impulse, and as a result of that, they may trigger the ventricles to start contracting too much. For example, when you learn CPR, you learn that ventricular fibrillation can occur. Now, if you think about fibrillation, you need to think about the fact that these two ventricles, rather than forcefully contracting, are now sitting there quivering, because they're receiving electrical impulses from lots and lots of different areas, and they're not working together, so subsequently they are quivering. Now, as a result of the quivering, there's not blood being ejected into the pulmonary artery and the aorta, and you're not going to feel a pulse, and because you didn't feel a pulse, then you started CPR. Now, where can we take pulse? Please refer to your anatomy and physiology book for a picture of where we can take pulses. We can take them over the temporal bone. This is an easy site to do, and you see this used by the anesthesiologist in surgery because they're right up there at the head, providing the gas that is causing this patient to be unconscious during the surgery. So it's a very easy site to use. The carotid pulse, which is located in the neck, again is very easily accessible, and this is the pulse site that you were taught when you learned CPR. Very important artery, the carotid, because it supplies the brain with blood. Apical pulse is a pulse that you do not palpate. You have to use your stethoscope and auscultate the pulse, and we auscultate it at the apex of the heart. Now, the landmarks that we use to determine where the apex of the heart is is left midclavicular line, fifth intercostal space. Now, the easiest way to find this is to put your fingers along the sternum, beginning at the very top, and you will feel a bone, and then you feel an indentation. And remember, that indentation is known as an intercostal space. So you feel the bone, you come down, that's one intercostal space. You feel the bone, come down, second intercostal space, and you keep going to, you get to the fifth intercostal space, and then move to the left to the midclavicular line, and that is where you're going to be able to hear the apical heartbeat so that you can count it. Now, one problem with this is in women, you will have to manipulate the breast to get the breast out of the way. In men, oftentimes it's real easy to do because that spot is going to be almost directly below the nipple. Of course, in children and infants, that's an easy area to find. Now, the reason why I said to start counting the intercostal spaces close to the sternum is because of the fact if someone has a lot of subcutaneous tissue, you're not going to be able to palpate those intercostal spaces as readily as you can if you were assessing on that left sternal border. This is the pulse site that we use in infants to know what their heart rate is, and it is really recommended to be used in children under 3. That doesn't mean that we don't try to palpate pulses in other sites, but all we're doing to those other sites is palpating for what the amplitude is and verifying that yes, blood is going through those blood vessels like it's supposed to. Now, the brachial is located in the antecubital fossa. Essentially, what that means is put your arm in anatomically correct position, which means that the palm is going to be facing forward. If you have the arm extended like you should, there will be an indentation at the elbow, and then you will have to palpate that pulse and roll it up against the bone underneath it. So you're going to be moving medially. This seems to be a pulse that some students have difficulty finding, and usually it's because they're not rolling that pulse medially. So find the little indentation in your arm and then pull it towards midline. Now, this is also the pulse site that we use to place the stethoscope over that brachial artery. So you have to know where the brachial artery is and have palpated it. Otherwise, you're really not going to know where to put the stethoscope when we get ready to assess that individual's blood pressure. The radial artery, radial pulse, is found on the thumb side of the forearm, and this is the most common site that we use in assessing pulses. The easiest way to palpate a radial pulse is to place the palm of your hand on top of the forearm, wrap your fingers around their forearm on the thumb side, and roll that artery up against the radial bone to palpate it. Because remember, to palpate pulses, you have to be able to feel that pulsation against a bone. Ulnar The ulnar artery is one that we don't use very often. However, if a patient is going to have arterial blood gases drawn, because that needle is going into the radial artery, they want to make sure that that ulnar artery is getting blood through it. So you will see them use it, and this is called an Allen's test when they're palpating for the ulnar artery. The femoral artery is in the groin area. It assesses circulation to the lower leg. You will see this artery palpated during CPR so that they know that compressions are occurring like they should, because during CPR, if you are doing your compressions appropriately, you will be able to palpate pulses. They can also use this artery to assess, to obtain blood for arterial blood gases. Popliteal pulse site is located behind the knee, oftentimes very difficult to find. However, if we are doing a lower extremity blood pressure, patient has reasons why we cannot use their arms to take a blood pressure, and we're having to assess a blood pressure in the leg. The blood pressure gets wrapped around the thigh, and then the stethoscope is placed over the popliteal artery behind the knee for us to assess that blood pressure. Posterior tibial is on the inner side of each ankle below the medial malleus. So you find your ankle bone medially, which is the inner side, and you should be able to palpate. Now notice it says posterior tibial. That's the name of the artery, and it does tell us about circulation to the foot. Another very, very common pulse site that we use is the dorsalis pedis, also known as the pedal pulse, P-E-D-A-L, which is located along the top of the foot. And it tells us whether or not, or how well this foot is receiving blood. The easiest way to find the pedal pulse is to take your index finger and your middle finger and place them on top of the great toe and the second toe, and move your hand up the foot to the top of the foot, and then compress. Now, as I stated earlier, this dorsalis pedis is going to have about a 1+ amplitude. So if you go to pressing too hard, you will compress that artery shut, and you will not be able to feel that pulsation that you need to assess. Oftentimes, we have to determine if a patient has what is known as a pulse deficit. What this means is, what is the difference between what you got when you listened to the apical heart rate and what did you get as a rate when you assessed the radial pulse? With the assessment for a pulse deficit, it requires 2 nurses. One nurse is going to be responsible for placing the stethoscope at the apex of the heart. The other nurse places her hand over the radial artery to be able to count the radial pulse. They use the same clock or watch, and they start at the same time. Each one counts the pulse for 1 full minute, and then afterwards they compare the results. Now, if everything in the body is working like it's supposed to, the apical rate will be the same as the radial rate. But if there is a problem with blood flow going to that radial artery, the results are not going to be the same. Now, typically what this means is when the heart contracted and blood was ejected, there wasn't enough blood that got ejected that created that pulse wave to go all the way down to the radial artery like it's supposed to, and it was not felt. This is always a reportable assessment finding because it is abnormal. As with any vital sign, we have to assess for, okay, what are some of the things that are going to affect what my result is going to be when I assess this pulse? Whether or not you're listening apically or you are palpating a pulse in an extremity. Now, heart disease, cardiac dysrhythmias. Cardiac dysrhythmia means that the heart is not contracting like it is supposed to. Therefore, you're going to be feeling quite commonly an irregular pulse. Chest pain or any acute pain from any other site is very definitely going to affect the pulse site. Remember that pain will trigger the sympathetic part of the adrenergic system, and the heart rate can go up. Surgery, cardiovascular changes. One really important thing is occasionally a patient will receive a sudden infusion of IV fluids. They get too much IV fluids, increasing the blood volume. Very definitely going to change rate, very definitely going to change pulse amplitude. Hemorrhage, blood loss. Because there's less blood being circulated, the heart rate is going to speed up, trying to make that lesser amount of blood do the job that should be being done by the normal 5 liters that we're supposed to have. Of course, medications, age, exercise, and let me make this comment about exercise. In individuals who exercise a lot, their heart rates at rest may run 30 to 40 beats per minute. Now, in anyone else, we would be greatly concerned about that. In them, because all of their muscles have been toned, and the heart is a muscle, that muscle has also been toned, so it doesn't have to work as hard, and their resting heart rates are going to be much lower than what we consider a normal heart rate to be. And when they start exercising, their heart rate is going to increase, but probably with you or me, when we exercise, our heart rate goes up to 120. When they exercise, their heart rates may only go up to 80. Position changes, we already have talked about, can cause changes in heart rate because we talked about orthostatic hypotension in mobility. Body temperature. As I mentioned at the beginning of the lecture, that we don't look at a vital sign by itself. We compare each of the vital signs to each other. Notice here it tells you that for each degree of elevation of body temperature, the pulse rate's going to go up 7 to 10 beats per minute. Now, the reason why the body's doing that is because of the fact it's trying to cool the body down. Sympathetic stimulation, we already know, is definitely going to affect the pulse rate. Blood pressure, if it is increased, typically the pulse decreases, and then if the blood pressure is decreased, typically the pulse increases. This is the body's way, again, of trying to protect itself. In endocrine system, you learned about the hormone thyroxine, which is secreted by the thyroid gland and is responsible for metabolic rate. If there's too much of that hormone being kicked out by the thyroid gland, the heart rate's going to elevate. And then if there's not enough thyroxine being kicked out and the patient has hypothyroidism, the heart rate is going to decrease. Yeah, how are we going to know whether or not this heart is pumping out the blood like it's supposed to? We already know that we're going to see a change in pulse amplitudes and pulse rates, but there are also associated symptoms that we want to look for. Are they having dyspnea? Difficulty breathing? Are they complaining about being fatigued all the time? Do they have chest pain? Orthopnea means that they can breathe when they are sitting up. So they may tell you, I have to sleep on 3 pillows at night, or I have to sleep in a recliner. That's a key thing that, as a nurse, you should investigate to try and determine, okay, it's not normal for us to sleep on 2 or 3 pillows or for us to sleep elevated in a recliner. Palpitations, by definition, palpitation is an uncomfortable awareness of the heartbeat. In most people, we know that our heart is beating because we're awake, alert, and oriented, and we're functioning, and don't really pay a whole lot of attention to that heart until something changes. You may exercise and all of a sudden you feel like your heart is beating out of your chest. That is called palpitations. Syncope. Syncope is fainting. Always an indicator that blood did not get to the brain like it was supposed to. Edema of dependent body parts, which means if they're sitting or standing a lot, we're going to be looking for edema in the feet and the ankles. Now, remember, when you are assessing edema, you need to assess where all is it. Is it pitting or non-pitting? Use the scale. If it is pitting, if it's 1+, it means when you compress over a bone, that pit is there, but then it immediately goes away. With 4+ pitting edema, when you place your finger over the edematous area, that pit stays there for about 5 minutes. So we know that there's a whole lot of extra fluid in that interstitial space. Now, edema tells us a whole lot about cardiac function because of the fact that fluid will end up staying in that interstitial spaces and not being drawn in. Cyanosis, we already know, is a bad thing. And then pallor of the skin. Peripheral vascular disease, we've talked about before, and oftentimes when you just look at a patient during your head-to-toe assessment and you see that their legs are pale in color, that their skin is very, very shiny, and that they have no hair whatsoever on those legs, pretty much know that this patient has peripheral vascular disease. Then when you palpate their skin, it will be cool because of the decrease in blood supply getting to that area. And because nails are important in many ways, but when blood supply is not what it should be, those nails do begin to thicken up. Okay, what unexpected outcomes can occur from assessing a pulse? One is they can develop bradycardia. Brady, as you have learned, means slow. And in this particular instance, we're looking at an adult heart rate less than 60. Other things that we would assess for to try and determine the reason why their heart is beating less than 60 times per minute is, what's their blood pressure? Again, it goes back to, you do not look at any one part of the vital sign assessment by itself. We have to look at other vital signs to see if they're correlating. If the heart rate is less than 60, the blood pressure is going to go down because the stroke volume has definitely been affected. We would want to know, are they having chest pain with this? Have they fainted? Are they diaphoretic? Anytime you find a radial heart rate of less than 60, it is critical that you assess that apical heart rate as well, because the apical pulse is what that heart is doing, and we need to be listening to that heart to see if there is any abnormalities in that. We look at what medications are they on. There are all kinds of cardiac meds and blood pressure meds that can affect the heart rate, making it go down. Have another nurse assess it. It is okay for someone else to assess what that pulse is. And then we would contact the physician for an EKG so that we would be able to look at it and determine what is going wrong with that electrical conduction system to give us a rate less than 60. Anytime you have an irregular rhythm, the heart rate is always assessed for 1 full minute. We auscultate it, and then we do assess for a pulse deficit. Now, how do we assess a pulse? We want to assess if they've had any caffeine intake, what their activity pattern has been prior to the assessment, have they been smoking within 15 minutes before us doing our assessment. All of these are part of the variables that were mentioned earlier that are going to affect what the results are going to be. The equipment that you need is a watch with a second hand on it. You want to provide privacy, perform your hand hygiene, and put on gloves if needed. In doing a radial pulse, you place the forearm straight along the side of the body, or you can place it across the lower chest or the upper abdomen. If you are doing a respiratory assessment as your next assessment, placing the arm in that position makes it a little bit easier to count how many times they're breathing. If they're sitting in a chair, flex their elbow to 90 degrees, make sure that the arm is supported. And then place the tips of the first 2 fingers over the artery site. And as I mentioned earlier, the palm of your hand should be over the forearm so that you can lightly compress that artery against the bone. We assess for the presence of each artery bilaterally, but we only have to count 1. Just because they have a left radial pulse does not necessarily mean they have a right radial pulse. So you always want to make sure that both are present. Most of you are used to only reporting what the rate is. Oh, their pulse was 82. As a nurse, you now need to be thinking about, yes, the rate was 82, the rhythm was a regular rhythm, and the pulse had a 2+ amplitude, if that's what the results were that you received. No longer should you be just reporting what that rate is. Now, if they have a 1+ amplitude, meaning that it's difficult to palpate that pulse, you want to assess the other pulse site. So if it's in their left foot, you would assess the right foot. Assess for signs and symptoms of decreased tissue perfusion, such as cool, pale skin. Assess for any edema that might be in the area. And then we have a wonderful thing called a Doppler that can listen for heart beats, pulsations, and then again, ask somebody else to assess it. Utilize your coworkers to validate your assessments. If you have a pulse in an adult that is greater than 100, that is known as tachycardia, and it is a cause for concern, and it is up to the nurse to start going through this list of probable causes. What was their temperature? Was their temperature 103? Then you're going to expect them to have tachycardia. Did they just get some news over the telephone that was very upsetting and the sympathetic nervous system got kicked in, elevating the heart rate? But then we also have to be concerned, especially in our post-operative patients, we need to be looking at, okay, what is their blood pressure? Because when the blood pressure goes down, the heart rate is going to go up. Have they lost blood? Now, keep in mind with surgical patients, if they've had hip surgery, they can lose 750 milliliters of blood in that hip, and if we're just looking at the wound, all of that blood is dispersed internally. We're not going to be seeing any outward signs of that other than the changes that are going on in the vital signs. Inadequate oxygenation. If their pulse ox is low, okay, if their pulse ox is 65, the heart's going to speed up, as well as the respirations are going to speed up to try and get more oxygen and nutrients going to the cells that need to be being fed: the heart, the brain, the lungs, the kidneys. And again, we want to be assessing for doing an apical pulse and contacting the physician so we can actually look at an EKG and see what's going on electrically in that heart causing this elevated pulse rate. Now, in children under the age of 2, we use the apical, femoral, and brachial pulses. Remember, in infant CPR, it was a brachial pulse that you assess for. It is not unusual for children to have what is known as a sinus arrhythmia. What a sinus arrhythmia is, when you are palpating that pulse, you will notice that it has an irregular rhythm, and that the heart speeds up when they take a breath in, and as they breathe out, the rhythm slows down a little bit. That is not any cause of concern. Some adults also have sinus arrhythmias that need to be addressed. The other thing that we have to keep in mind when we're looking at age is our geriatric clients. With our geriatric clients, they don't respond to stress, illnesses as healthy adults do. Sometimes you have a geriatric client who has a heart attack and they do not present with normal symptoms, what we call normal symptoms of crushing chest pain, shortness of breath, diaphoresis, with an MI. Now, how do we check an apical pulse? Because this is an extremely important assessment that we do. Now, there are different places that we listen to the heart based upon which heart valve do we want to be listening to. In Blackboard, you have a document labeled heart sounds, and when you look at that document, it shows you a picture of the 5 different places in which we listen to the heart to try and determine, is there a problem with any of the valves. It is important for you to know how to put the stethoscope in your ears, because if you don't put the stethoscope in the ears correctly, you will not be able to hear as well. So what you do is hold your stethoscope with the earpieces that are going to be pointed towards your face, which means that they're going to be pointed outward. Most stethoscopes have a diaphragm portion and a bell portion. The diaphragm portion is the flat, solid side, and the bell is open. Diaphragm is used for high-pitched sounds, and the bell is used for low-pitched sounds. Now, what are we hearing when we listening to a heart? We are listening to valves that are snapping shut after blood has been ejected from that portion of the heart. They're labeled as S1, commonly known as a lub, and this is the closure of the tricuspid and mitral or bicuspid valve, as the mitral valve is also called. These are the 2 valves that are located between the atria of the heart and the ventricles of the heart. So the atria contract, the valves open up, allowing blood to get down into the ventricles, and then they snap shut, and we hear an S1. S2 is the closure of the pulmonic and aortic valves. So these ventricles are going to contract. Blood will go through the open pulmonic and aortic valve to either get blood to the lungs or blood to the rest of the body. And then when they snap shut, we hear an S2. Now, oftentimes you're kind of unsure, am I listening to S1 or S2? What you can do is palpate the carotid pulse while you are auscultating with the stethoscope at the left 5th intercostal space, mid-clavicular line. You hear a sound, you feel the pulse, and you hear a sound. The sound that you heard before you felt the pulse is the S1, and then the sound that you heard after you felt the pulse is the S2. Now, in some individuals, you may have difficulty hearing the pulse, so you can have them turn on the left side, and what this does is bring that heart closer to the chest wall so that you can auscultate it. If they are sitting in a Fowler's position or a high Fowler's position or sitting in a chair, you can have the client lean forward, and again that brings the heart closer to the chest wall surface. Now, in infants, where you place your stethoscope, and you need to really be using a pediatric stethoscope that has the smaller diaphragm and bell. We listen to the left third to fourth intercostal space near the left sternal border. Keep in mind that with apical pulses, they are counted for 1 full minute. Now let's move on to respirations and respiratory assessment. It is extremely important that there is an exchange of carbon dioxide and oxygen between the cells of the body and the atmosphere. Respirations are controlled by the pons and the medulla oblongata. Normally, we don't even pay attention to the fact that we are breathing. We know that we are because we are doing the activities that we're doing. But we can also control them ourselves if we need to or we want to. It is extremely important to keep in mind that there are chemoreceptors located in the carotid arteries and the aorta, and that they are detecting how much carbon dioxide is in the body. And it is the level of carbon dioxide that determines what our respiratory rate is going to be. Now, we have a whole group of students who have chronic obstructive pulmonary disease, and then their drive to breathe becomes low oxygen levels rather than what the carbon dioxide levels are, because in these individuals, they typically run high carbon dioxide levels, and the medulla oblongata has kind of gone, okay, don't need to be paying attention to that, and now we need to be looking at what's their oxygen levels. Respirations are 3 processes: ventilation, which is the mechanical movement of gases into and out of the lungs. And really, we call it assessing respirations, when in actuality, what we are assessing is that ventilation process. Diffusion is when the oxygen and carbon dioxide are being moved out of the alveoli and into the red blood cells with external respiration, and then with internal respiration, the movement of the oxygen and carbon dioxide between the red blood cells and the body cells. Perfusion is that distribution of red blood cells to and from those pulmonary capillaries. So you see what normal results should be. Eupnea is the medical term for normal respirations, which are defined as effortless, quiet, with equal bilateral chest expansion and a regular rhythm. So air in is inspiration, air out is expiration. Remember, with inspiration, that diaphragm's going to contract and flatten out, and the ribs and the sternum are going to lift outward by muscle use to expand lung expansion, and then with expiration, the opposite thing happens. Again, we want to look at variables as to what can cause respiratory rates to change. And some of these are the same thing that we see as variables that affect all of the other vital signs. But things we have to look at is, do they have an abdominal incision? If they have an abdominal incision that is close to in the upper abdomen, they're going to be less likely to want to breathe very deeply. And then atelectasis can occur, because of the fact when they take a deep breath, it causes them pain, and they don't want to be in pain. Gastric distension, if their belly is full of air, they're not going to be able to take a deep breath because they cannot flatten out that diaphragm. Then we have COPD, which consists of the 3 diseases of emphysema, bronchitis, and asthma. very definitely are going to affect everything in relationship to respirations. What the rate is, what the rhythm is, what the effort is. And then, of course, traumatic injuries, or do they have a chest tube? Do they have a tube that is going up into that pleural space? Any infectious process. Pulmonary edema is when there is fluid in the alveoli themselves. And there shouldn't be fluid because that's going to affect how much oxygen and carbon dioxide can be exchanged. Head injury with damage to the brain stem. Musculoskeletal deformities. So we have to look at, do they have scoliosis? Do they have kyphosis, or lordosis doesn't affect it, but the kyphosis definitely will. Then we want to look at, okay, what signs and symptoms are they having related to what the rate, rhythm, and depth of the respirations were. Are they cyanotic? I will tell you that the number one thing that we look for is restlessness and irritability in clients, because that is usually the first sign of hypoxia. When the brain doesn't get enough oxygen to it, that individual is going to get restless and irritable. Adventitious breath sounds means when we are auscultating their lungs, we're hearing things like crackles, wheezes, and the term adventitious relates to that. If they're coughing up sputum, keep in mind sputum comes from the lungs. What does it look like? If it's very thick, if it's frothy, if it's blood tinged, we really need to be addressing. ABGs, you got to know these normals. pH 7.35 to 7.45, PaCO2 35 to 45, PaO2 80 to 100, HCO3 22 to 28, and then SaO2 95 to 100%. Now, this is with ABGs. Needle has been inserted into the radial artery, blood has been obtained and taken to a machine that is going to tell us what these numbers are. Pulse oximetry, we put a little instrument on their finger, and it's going to measure how much oxygen is saturated on the hemoglobin on the red blood cells, and it should be 95 to 100%. Now, anytime you're looking at a pulse ox, you need to know what is that patient's hemoglobin. That is very, very critical. If you remember, I drew box cars on the board and showed you that a patient who only has a hemoglobin of 6 can have 100% pulse ox, but that does not mean that they are not hypoxic. They only have half the number of box cars carrying oxygen that they need, and they will be hypoxics. Now, it's not going to be unusual if you have a patient who has COPD for them to run less than 95%, but we still use 95% as, okay, we need to be looking at what that causes. In assessing respirations, probably the key critical thing is you need to assess them when they are unaware of what they are doing, what you are doing. Each inspiration and expiration count as one respiration. So you are looking at that chest rising and falling, or you're feeling for that chest rising and falling, and each rise and fall is 1, rise and fall 2. You also need to be assessing what that rhythm is. If it is irregular, you must count the respiratory rate for 1 full minute. Otherwise, you can just count it for 30 seconds, multiply that number times 2, and that gives you the result of what their respiration is for 1 full minute. You also need to be looking at the depth of the respirations. Are they breathing deeply? How much effort are they having to use to breathe? Okay, this gives you a lot of terminology that defines alterations in breathing patterns. You already know that the prefix a means without, and the suffix or root word pnea is referring to respirations. Now, apnea needs to be timed. Get your watch, use the second hand on the watch, and time. How long are they not breathing? Biot's is an interesting respiratory pattern in the fact that the respirations are irregular, vary in depth. They do have periods of apnea, and we see this in patients who have increased intracranial pressure. So we have a patient with a history of a head injury, and we're assessing their respirations and notice this is occurring. Bradypnea, because Brady means slow, is a rate less than 12 per minute. Cheyne-Stokes, the rate and depth are irregular. They will have alternating periods of apnea and hyperventilation. So what you are seeing is the respirations begin slow and shallow, then gradually increase to an abnormal rate and depth, and then the pattern reverses and they have apnea. Hyperpnea is an increase in depth. Hyperventilation is where the rate and the depth both increase, and we worry about this because they are blowing off a whole lot of carbon dioxide. And remember, it's the amount of carbon dioxide that determines what our respirations can be. So sometimes when patients are hyperventilating and they get rid of too much CO2, they may pass out and quit breathing, and then when the CO2 levels rise again, they'll start breathing again. Hypoventilation, the rate is less than 12, and we worry about that because then they're going to be retaining CO2, and if they retain CO2, they're going to end up in an acidotic state. Kussmaul's respirations are rapid and deep. They are regular, and we see this quite commonly in patients who have diabetic ketoacidosis, which is a form of metabolic acidosis. Tachypnea greater than 20. Remember that sighing is a normal physiological mechanism to expand smaller airways. So it's not always a bad thing that people are sighing, and oftentimes people will sigh, not realize that they did, as the body's attempt to get air down into the bases of the lungs. So what are we going to do if we see any of these abnormal patterns? You need to look at, okay, what could be the probable cause, listen to their lungs, provide oxygen, and very definitely notify the healthcare provider. When we auscultate for breath sounds, we auscultate in all areas of the lungs. When you hear adventitious sounds, crackles are generally due to the fact that there's alveoli in the lung. Rhonchi and wheezes are due to constricted airways, like you might see in patients with asthma. A stridor is a very high-pitched, horrible sound that means typically we've got a laryngeal problem going on, and a stridor needs to be evaluated immediately. A pleural friction rub is a sound that you will hear when the visceral and parietal pleura are not working together. There are all sorts of websites on the internet that you can go to listen to all of these different types of adventitious. 95 to 100%, great, less than 85%, we are severely concerned. And as I mentioned earlier, we do really need to know what that patient's hemoglobin is to effectively evaluate what the results mean. So here's a picture of a pulse ox. They have smaller ones that individuals can buy at Walmart. So you have some patients with COPD that will have their own pulse ox that they can put on the patient, put on their finger. Light waves are used to calculate what the oxygen saturation is. Remember that we're looking at, is it oxygen that has been bound to the red blood cells, or is it something else? You may have a patient with carbon monoxide poisoning, and because the red blood cells would rather pick up carbon monoxide than oxygen, they may come in with abnormal pulse ox readings. And then it is always critical to correlate that pulse rate, the pulse ox, with what the heart rate is. We can delegate this task to unlicensed individuals, but any abnormals really need to be evaluated by the nurse. Peripheral vascular disease, because they're not getting the blood flow, is going to affect what the results are. Vasoconstriction, if they're on any type of a medication that causes vasoconstriction, can affect the results. Hypotension, if they have a lot of peripheral edema, again, that will result. Blood pressure. Everybody hears about blood pressure, and it is extremely important. By definition, it's the force exerted against the blood vessel walls. It is going to be highest during systole, and remember that systole is when that ventricle is contracting, and it's going to be lowest during diastole, which is when that ventricle is at rest. Typically, we don't measure blood pressures in children under the age of 3 unless they do have some sort of a cardiac disorder. Now, blood pressures tell us a whole lot about the body because it tells me about the volume. If the volume is low, then I have a decrease in blood pressure. If the volume is high, then I'm going to have a high blood pressure. Tells me about stroke volume. How much blood did that ventricle eject when it contracted? Did it eject that normal 70 milliliters that it's supposed to? Tells me about what's going on with the blood vessels themselves. Are they vasodilated? And if they are, the blood pressure is going to be lowered. Are they vasoconstricted? And the blood pressure will be higher. Now, we use a blood pressure cuff, which is medically known as a sphygmomanometer and a stethoscope, and then we do have electronic machines to take blood pressures. Just because you have an electronic machine does not mean that you do not need to know how to do this skill, because sometimes those machines are not calibrated correctly. We are going to place the blood pressure cuff over the upper arm, place the stethoscope over the brachial artery, pump the cuff up, and then start letting the air out of the cuff. And the first sound that we hear will be the systolic pressure, and then the last sound that we hear is the diastolic pressure. Another term that you need to know is what the pulse pressure is, and this is what the difference between the systolic and diastolic pressures. Normally it's 30 to 60 millimeters of mercury, and it does give me information about what their cardiac output is. Hypertension, common disorder. Lots of people have hypertension and don't know they have it until they go to a health fair and get their blood pressure taken and it's elevated. Normal we consider to be less than 120/80. Pre-hypertension is 120 to 139/80 to 89, which means that these patients really need to start doing some healthy living so that they don't develop hypertension, and then it is staged. Really, before we say that someone has hypertension and start putting them on medications, we need to take the blood pressure on 3 separate occasions to make sure that that rate is elevated. The most common type of hypertension is known as primary hypertension, which means we really don't have a clue as to what is causing the hypertension. One key thing we know is that we probably have a lot of sympathetic nervous system going on that is causing it. And then secondary hypertension means we know what the cause is, and typically it is due to kidney disease, because the kidney plays an extremely important role in hypertension, because it triggers the renin, angiotensin, aldosterone system in regulating blood pressure. If you remember, blood pressure is going to be related to the size of the blood vessels and what the blood volume is. And with this renin, angiotensin, aldosterone system, angiotensin 2 is the most potent vasoconstrictor that we have in the body. And then aldosterone tells the kidney to hold on to water, and between those two things, it's going to make the blood pressure go up. Hypotension is the opposite end, where a patient has a blood pressure less than 90/60, commonly related to hemorrhage, shock, myocardial infarction, orthostatic changes, or even medications. As I mentioned, the medical term for a blood pressure cuff is a sphygmomanometer. We need to look at using the correct size blood pressure cuff on an individual. The width of the cuff should be 40% of the limb circumference, or 20% wider than the diameter of the midpoint of the limb. If you use the wrong size cuff, you're not going to get the right blood pressure. So if you're trying to use a regular size blood pressure on an individual with extremely large arms and we need an extra large blood pressure cuff, the reading you get will not be correct. Lots of things affect blood pressure. And again, when you look at these, it's the same kinds of things that affect all of the other vital signs. Your blood pressure is highest between 10 o'clock in the morning and 6 o'clock at night. You're up and about and doing your job and that sort of thing. Pain will affect blood pressure. The severity of the pain will determine whether or not the blood pressure becomes hypertensive or hypotensive. Any type of shock is going to affect blood pressure, causing hypotension. As I mentioned, kidneys are an extremely important role in regulating blood pressure. So if a patient has a history of kidney disease, typically they're going to be hypertensive. All kinds of medications, if they smoke. Ethnicity, we know that typically blood pressures are higher in our African American population group. We look for other signs and symptoms to correlate with this blood pressure. If the blood pressure is high and they have hypertension, do they have a headache? Typically it's going to be an occipital headache. Facial flushing can occur. They can have a nosebleed. Sometimes that's the first clue that we have that a patient has hypertension. They go to the clinic and they say, I'm having nosebleeds all the time, and we take their blood pressure and it's extremely high. Hypotension is going to cause a decrease in the amount of blood getting to the brain. So you're going to see restlessness again as that first sign of hypoxia. Changes in level of consciousness, dizziness, and then there's going to be skin color changes as well. As a nurse, it is your responsibility to determine, where am I going to check this blood pressure? Am I going to check it in the right arm? Am I going to check it in the left arm? Am I going to check it in the legs? So we have to assess the patient. Do they have an IV infusing? Where is it infusing? Do they have a shunt or a fistula for renal dialysis, and where is that located? Have they had a mastectomy, or have they had any axillary surgery, because that's going to omit that limb? And then, have they had an injury? Clients really need to be at rest when we take them, so if they have had activity, have them rest, of course, unless we're doing orthostatic blood pressures. They need to be in a resting position with their feet flat on the floor. Their forearm is at heart level with the palm turned up. Typically we like to hyperextend the elbow. It makes it a little bit easier to palpate the brachial pulse and place the stethoscope over that area if we have hyperextended that elbow. Now, if we're having to do a lower extremity and we're placing that blood pressure cuff over the thigh, then the patient has to be in a prone position so that we can place the stethoscope over the popliteal artery. You absolutely, when you're doing a blood pressure in the arm over the upper extremity, you always palpate that brachial artery before you place that stethoscope over that area. You want the cuff on bare skin, always on bare skin. It is wrapped snugly there, about 1 inch over the brachial artery that you have palpated. And then blood pressures can be done in a two-step method. If it's the first time that you've checked a blood pressure, the two-step method is where you place the cuff on correctly, you palpate the brachial artery, you inflate the cuff. When you no longer are able to feel that brachial artery, you continue to inflate the cuff 30 millimeters more. You slowly deflate the cuff and you pay attention. When did I start feeling that pulse again? Now, when you feel that pulse again, that is telling you really what that systolic pressure is. So after you start feeling the pulse, go ahead and deflate the cuff very rapidly and fully. Wait 1 full minute, and now you can place your stethoscope in your ears, place either the bell or the diaphragm. Some people hear a blood pressure better with the bell portion of the stethoscope because it is a low-pitched sound. Other individuals always like to use the diaphragm. Over that brachial artery, you close the pressure bulb on the blood pressure cuff. And remember, it's always righty-tighty, lefty-loosey, which means it's going to be turned in a clockwise position until it's tight. And then you inflate the cuff 30 millimeters of mercury above what that systolic pressure was when you palpated for the systolic pressure. After you have it inflated to the point you need to have inflated, So let's say that my palpated systolic pressure was 120. I'm going to inflate the cuff to 150, and now I'm going to slowly release the pressure bulb and allow the needle to fall at 2 to 3 millimeters of mercury per second. If you open up that valve and you release the air too quickly, you are not going to get an accurate systolic or diastolic pressure. Now, the first sound that you hear will indicate what the systolic pressure is. You're slowly deflating it at 2 to 3 millimeters of mercury per second. You listen for the last sound, and that is your diastolic pressure. You continue to deflate it for about 30 to millimeters more below that diastolic pressure, and then you can just go ahead and let all of the air out of the cuff. If you're going to use a one-step method, what you need to do is know what their previous systolic pressures have been. So I look in the chart, I find what their pressures have been running, and I'm going to inflate the cuff 30 millimeters above what their usual systolic pressure is. Now, the reason why I'm saying this is the fact that a lot of people just want to pump those blood pressure cuffs up to 200 millimeters of mercury and then start letting it out. That's an incorrect method, and you do not get a correct blood pressure. Now, when we do this in the lab, we're going to do this step by step by step, and all of these instructions will be re-emphasized. If you're palpating a blood pressure, please keep in mind that the only part of the blood pressure that you will be able to determine is that systolic pressure, because remember that the diastolic pressure by definition is the last sound that we hear, and if we're palpating, we are not listening. What are some things that can happen? Orthostatic hypotension, we mentioned in the mobility unit, because of the fact when they change positions, their blood pressure gets lower. Sometimes physicians want us to assess blood pressures lying, sitting, and standing to determine do they have orthostatic hypotension or not. We talked about in the mobility unit about how important it was to dangle the client for 1 minute before we stand them up. They have their call light. They know to use the call light before they are transferring so that they don't end up having a syncopal episode. Hypertension. Anytime you get a high blood pressure, you should always evaluate their blood pressure in the opposite arm. Blood pressure should be pretty close to the same thing in the right arm and in the left arm, but occasionally you have a patient that is not true, and of course that would always be reported. Make sure you're using the right size of blood pressure cuff, that you have the cuff on bare skin. You're not trying to listen for a blood pressure over their clothing. Have another nurse assess it. Make sure that yes, they are getting it. If there is a digital machine that you could use, take the blood pressure with that digital machine to see if it is also giving a hypertensive reading. And then look for associated symptoms. Do they have tachycardia? Do they have bradycardia? Are they in pain? Are they anxious? And then, of course, it does get reported. Antihypertensive meds can be ordered, and there's different classifications of antihypertensive meds that we talk about. And then we do encourage lifestyle modifications such as no diet, no smoking, the DASH diet, weight control. Oftentimes patients who are overweight, when they lose weight, their blood pressure goes down. Physical activity, and then one key important thing is stress reduction, and oftentimes that's really difficult to do. Hypotension, we want to get them in a supine position, restrict their activity, reassess the measurement, look for associating signs, report it, and in a lot of cases, the physician may tell us to increase the rate of their IV infusion, or he may tell us to administer